Welcome to the Explainer. All right, let's talk about one of the most common and, let's be honest, frustrating challenges we face as residents. The patient who says they want to change but just can't seem to get there. Today, we're going to break down the tool designed for this exact problem and get you totally exam ready on motivational interviewing. Okay, so section 1. Let's start with a scenario you all know way too well. The ambivalent patient. They're stuck, right? They can tell you all the reasons they should change, but they're also being pulled back by all the reasons not to. And this is exactly where so many of our clinical conversations just grind to a halt. So, what's our first instinct when we see someone stuck? Well, we try to help. We give them really good, logical, direct advice. And it almost never works. In fact, sometimes it makes them dig their heels in even harder. So, what's going on here? Let's unpack why our best intentions so often backfire. Okay, this is absolutely key. What we often call resistance isn't really resistance at all. It's ambivalence. And ambivalence is a totally normal human thing. The problem is, when we push against it with advice, we trigger something called the righting reflex. You know, that deep-seated need we have to fix things. But when we do that, the patient's natural reaction is to argue for the other side, which just ramps up their defensiveness and, you guessed it, kills adherence. And this is exactly where motivational interviewing, or MI, completely flips the script. It's a patient-centered approach that says, hey, my job isn't to push you to change. Instead, it's about creating a conversation where the patient can explore their own feelings and ultimately find and strengthen their own reasons to change. We're not installing motivation, we're helping them find it. So, section 2. Before we jump into the actual techniques, the how-to, we have to get the philosophy behind MI. This is often called the spirit of MI. And honestly, if you don't get this part, the techniques won't work. It's a fundamental shift in our entire mindset. Look, this isn't psychoanalysis. We're not digging for some deep, unconscious conflict from their childhood. MI is a collaborative, here and now conversation. It's about working with the patient. That means we actively avoid things like confrontation, trying to persuade them, or just giving advice without getting their permission first. Think of it like this. It's a dance, not a wrestling match. The spirit of MI is built on these 4 attitudes. First, partnership. You and the patient are on the same team exploring this together. You're not the expert dictating terms. Second, acceptance. This means respecting their autonomy, their choices, even if you don't agree with them. Third, compassion. You're doing this to genuinely promote their well-being. And finally, the real game changer, evocation. The core belief that the motivation, the wisdom, it's all already inside them. Our job is to help draw it out. And those ideas lead us to these core assumptions. First, ambivalence is normal, not pathological. Second, the patient is the undisputed expert on their own life. And this leads to a really critical insight for your exams and your practice. The more a person argues for their own change, the more likely they are to actually do it. This right here is what we call change talk, and it's the holy grail of MI. All right, section 3, let's move from the why to the how. These are the practical skills you need. This is your super high-yield toolkit for the clinic and your exams, and you can remember it with the easy mnemonic OARS. Think of these as the oars you use to help steer the conversation toward change. First up, the O is for open questions. These are questions that can't just be answered with a yes or a no. So instead of asking a dead-end question like, do you want to stop drinking, which doesn't really get you anywhere, you ask something like, help me understand, what are some of the not-so-good things about your drinking? See how that just opens up the conversation? Next, A for affirmations. Now, this is not just cheap praise like, hey, good job. It's about genuinely seeing and acknowledging the patient's strengths, their past efforts, their character. Saying something like, wow, it takes a lot of courage to even be here talking about this, can do wonders for their confidence and their belief that they can actually change. Then we've got R for reflections. And I'm telling you, this is arguably the most powerful skill in the whole toolkit. You're basically making a guess at what the patient is trying to say, their underlying feeling or meaning, and you say it back to them. It shows you're really listening, it builds empathy, and crucially, it lets you highlight and reinforce all the little bits of change talk you hear. And finally, S for summaries. Think of this like collecting a bouquet of flowers. Throughout the conversation, you've been picking up on all of the change talk the patient has offered. At a transition point, you gather it all up, their desires, their reasons, their needs, and you present it back to them. It's an incredibly powerful way to let them hear their own arguments for change, all at once.
So, Section 4. If OARS are what you do, what are you listening for? Well, your main goal is to find and amplify change talk. And that brings us to our next super high-yield mnemonic, darn cat. This is how we categorize the specific language of change.
Now, here's the thing. Not all change talk is created equal. We break it down into two types. There's preparatory talk, that's the darn part. This means they're getting ready, they're thinking about it. Then there's mobilizing talk, that's the cat part. This is a much, much stronger predictor that they're actually about to do something.
So darn talk is the groundwork. You'll hear things like desire. I wish I could lose some weight. You'll hear about ability. I guess I could probably walk more. You'll hear reasons. My doctor said my blood pressure is too high. Or you'll hear need. I've got to do something about this. Your job, when you hear this stuff, is to use your OARs to get more of it.
Cat talk. This is where the rubber meets the road. This is the good stuff. You'll hear direct commitment language like, I'm going to start exercising tomorrow. You'll hear signs of activation like, I'm ready, what's the first step? Or they'll tell you they're already taking steps. You know, I actually went online and looked up gym memberships yesterday. When you hear cat talk, that is your green light. Okay, Section 5. We have the philosophy, we have the tools. Now let's put it all together. What does this actually look like in a real clinical encounter? This is how you connect all the dots, both for helping your patients and for acing your exams. This slide right here shows you the central engine of motivational interviewing. It's a feedback loop. As the clinician, you use your OARS skills. Your target is to hear darn cat language from your patient, and as soon as you hear it, you use more OARs, especially reflections and summaries, to amplify and reinforce it. This is how you build momentum for change. And here's the typical flow. It's not random. First, you engage to build that partnership. Then you focus the conversation on a specific behavior. The real work happens in evoke. That's where you're using OARs to pull out all that darn talk. You constantly reflect and summarize to strengthen it. And notice what's at the end? Planning. You only move to planning after you start hearing that strong CAT language. And the whole thing is wrapped in supporting the patient's autonomy. Okay, if you're taking notes, put a big start next to this one. This is a critical clinical pearl. If you jump into planning too early, before the patient has really talked themselves into changing, you're just going to trigger that defensiveness all over again and shut the whole thing down. You have to wait for the cat talk. All right, exam prep time. Here are your must-knows. First, if you're going to give advice, you always ask permission first. Would you be open to hearing an idea? Second, when you hit what feels like resistance, you don't argue. You roll with it by using a reflection. Third, remember that MI can be used in really brief interventions, not just 50-minute sessions. And finally, if a test question has you stumped, always pick the answer that emphasizes collaboration and patient autonomy. If you only remember one thing from this entire explainer, make it this sentence. Seriously, screenshot this, write it down, whatever you need to do. This is the perfect, concise summary for any exam question that asks for a definition or the purpose of MI. It's got all the key ingredients: collaborative, ORS, darn cat, and resolving ambivalence. So I'll leave you with a question to take with you to your next clinic. Think about your most stuck patient, the one you dread seeing on your schedule. How might shifting your own approach, from expert to partner, from confronting to collaborating, change the entire feeling of that conversation? It's a really powerful thing to consider. Thanks for joining us on The Explainer.